Bismillah ar-Rahman ar-Rahim. This lecture within the Cardiology Department, Cairo University e-learning program. We will discuss post-myocardial infarction complications and risk stratification. It is well known that acute myocardial infarction is one of the leading causes of death worldwide. There is a wide range of complications that occurs post-myocardial infarction and can be classified to hemodynamic disturbance, arrhythmia and conduction disturbance, mechanical complications, and others. First, hemodynamic disturbance. Heart failure is the most frequent complication and one of the most important prognostic factors in patients with STEMI. This graph showing the rate of sudden death or cardiac arrest stratified by the time from the onset of MI. The high rate of sudden death came within the first month after MI in all strata of left ventricular ejection fraction and declined exponentially to a plateau at 12 months. But the highest rate is among patients with ejection fraction less than 30%. In patients with STEMI, either systolic dysfunction alone or both systolic and diastolic dysfunction can occur. Heart failure can be acute, subacute, transient due to stunning or resistance. In addition to the infarct size, other important factors are contributing in development of symptomatic left ventricular dysfunction. This includes advanced age and diabetes. Although left ventricular dysfunction is the most frequent cause of heart failure, hemodynamic and rhythm disturbance, as well as mechanical complication and valve dysfunction should be ruled out. Patients with heart failure present with symptoms of pulmonary congestion, hypotension, mean resistant systolic pressure less than 90 mm mercury, low cardiac output symptoms. There is hypotension in addition to sign of poor peripheral perfusion and cardiogenic shock. The diagnosis made by typical symptoms, full clinical examination, ECG that may show sinus tachycardia, left atrial abnormality, X-ray could show cardiomegaly, pulmonary congestion, and clinical risk assessment, and most importantly, transthoracic echocardiography, by which we could assess the left ventricular function and presence of complications. The management: first, continuous monitoring of heart rhythm, blood pressure, and urine output. Coronary vascularization is a mandatory step. Detection and correction of correctable cause and standard medical therapy. The ACE inhibitors, beta blocker, and mineralocorticoid receptor antagonists are important in hemodynamically stable patients, those with evidence of ejection fraction less than 40% or heart failure, and these agents are important to reduce risk of hospitalization and death. Loop diuretics and nitrates are essential for symptom relief and reduce the fluid overload in patients with systolic blood pressure more than 90 mm mercury. Oxygen can be given for patients with saturation less than 90%, aim to maintain saturation above 95%. More advanced treatment with patient intubation and non-invasive ventilation, either CPAP or BiPAP, is essential for patients with hypoxia, hypercapnia, and evidence of acidosis to improve the ventilation. Then, intravenous nitrates and sodium hydroxide is indicated in patients with heart failure and elevated systolic blood pressure to control blood pressure and symptoms. Sedation can be given for, and morphia can be given for patients to relieve symptoms and pulmonary edema. Second, the right ventricular involvement. Right ventricular infarctions complicate approximately 1/3 of patients with inferior STEMI. The clinical triad of hypotension, clear lung field, elevated jugular venous pressure is characteristics. The diagnosis can be made by ECG with presence of elevation ST segment more than 1 mm in these AVR, V1 or in the right precordial leads V3R and V4R. Echocardiography is commonly used to assess RV function and presence of segmental wall motion abnormality. The management of RV ischemia includes early coronary reperfusion, particularly opening the RV branch of right coronary artery, which may result in a rapid hemodynamic improvement after restoration of the blood flow, and improvement also avoidance of therapies that reduce preloads as nitrates and diuretics, correction of AV dysynchrony, correction of atrial fibrillation, and if needed, we may use inotropic support in severe hypotension. Cardiogenic shock remains the most common cause of death in patients admitted with anterior STEMI or acute myocardial infarction in general. Mortality remained nearly unchanged in the last decades and range to between 40 to 50%. This table showing the definition applied in European guidelines and select major randomized trials. Generally, cardiogenic shock is defined as the state of critical end organ hypoperfusion and hypoxia due to primary cardiac disorders, and clinically defined as persistent hypotension, systolic blood pressure less than 90 mm mercury with clinical and laboratory signs of hypoperfusion. The incidence of cardiogenic shock range between 3 to 30%, with in-hospital mortality more than 50%. The causes of cardiogenic shock usually left ventricular dysfunction in 80% of cases, RV dysfunction in 7%, and presence of mechanical complication in 13%. Patients with complicated cardiogenic shock usually more likely to be older in age, with history of diabetes, previous myocardial infarction, heart failure, and sustained an anterior infarction at the time of presentation and development of cardiogenic shock. The pathophysiology of cardiogenic shock appear to be due to results of a vicious cycle, where a low cardiac output lead to more hypotension, less coronary perfusion, more ischemia, and lead to progressive myocardial dysfunction. So, to abrupt this cycle, early coronary revascularization is the most important treatment strategy in cardiogenic shock after myocardial infarction. For patients presented to a non-PCI capable hospital, fibrinolysis is class 2A indication in the European guidelines. These recommendations based on data came from SHOCK trial. Early revascularization is the most important treatment strategy in cardiac shock after myocardial infarction. However, this trial failed to meet the primary endpoints of lowering the 30-day mortality with early revascularization when compared to the medical stabilization. However, there was an evidence of significant mortality reduction at long-term follow-up up to 6 years, especially in subgroup of patients, such patients over 75 years old presented with cardiogenic shock during STEMI. The after-invasive monitoring of these patients, pulmonary artery catheter Swan-Ganz can be used to confirm the diagnosis and guide therapy. Invasive blood pressure monitoring by arterial line is essential. Then echocardiography play an important role to identify the mechanism of cardiogenic shock, to manage the complication, to detect any complication and any correctable cause. The pharmacological therapy aim to improve organ perfusion by increasing the cardiac output and blood pressure and reduce the volume overload. So diuretic therapy is essential to reduce the volume overload, and in resistant case, ultrafiltration can be considered. Inotropic and vasopressor agents may be used for hemodynamic stabilization to maintain systolic blood pressure more than 90 mm mercury. Intra-aortic balloon is one of the oldest and most often used mechanical device to support circulation for decades. However, it doesn't improve the outcome in patients with ischemia and cardiogenic shock without mechanical complication, nor does nor does it signify limit infarct size in those patients. So, routine intra-aortic balloon cannot be recommended, but it must be used in selected patients. Short-term mechanical circulatory support device as Ambilla and phantom heart have been used in patients who are not responding to the standard treatment. And this therapy can be used in certain patients to stabilize patients, preserve the organ perfusion as a bridge to recovery of the myocardial function or to support during PCI procedure. This is an example of an 8-year-old male patient who presented with inferior MI. His diagnostic angiography show heavy calcified multivessel disease with central score of more than 40 and ejection fraction of 25% with unstable hemodynamics. So the patient and surgeon refused to do it, to go for surgery. So, and with the assistance of Ambella, we could achieve complete revascularization of the right coronary by root ablation and drug-eluting stents and PCI to the left main LAD with root ablation. Second part is the arrhythmia and conduction disturbance. These arrhythmias are common during the early hours of ischemia and it's an important prognostic factor. They have also the presence of re-entry circuit within the ischemic myocardium. Sudden cardiac death may occur due to fast VTAC and ventricular fibrillation in the pre-hospital phase. Early perfusion therapy reduces the risk of ventricular arrhythmia and reduce cardiac death. Careful use of antiarrhythmic is generally recommended, and alternative treatment options such as electrical cardioversion, wait-and-see strategy for arrhythmia with no or moderate hemodynamic relevant, or in selected cases, cardiac pacing and catheter ablation could be applied. Most importantly, correction of electrolyte imbalance and early treatment with beta blocker, ACE inhibitor, and ARBs and statins is recommended to reduce the occurrence of these arrhythmias. Atrial fibrillation is the most frequent supraventricular arrhythmias occur in myocardial infarction. It's common up to 20%. Usually, it's well tolerated by the patient. Patient presented with atrial fibrillation have usually multiple comorbidities. They usually elderly presented with heart failure and hypotension. The mechanism for occurrence of atrial fibrillation is excessive sympathetic stimulation, atrial stretch, atrial infarction, presence of pericarditis, electrolyte abnormality, hypoxia, or underlying lung disease. Several studies showed that the new onset atrial fibrillation can be reduced by early beginning of beta blocker, ACE inhibitors, and statins in setting of myocardial infarction. For the management, for acute rate control, intravenous beta blocker is indicated to control rate if there is no evidence of heart failure or hypotension. Intravenous amiodarone indicated to control rate in patients with heart failure with no hypotension, and intravenous digital is considered to control rate in patients presented with heart failure and hypotension. Then immediate electrical cardioversion is class 1 indicated in patients with hemodynamic abnormality with failure of the pharmacological agent to control the rate, or there is evidence of ongoing ischemia or severe hemodynamic abnormality. Importantly, patients with atrial fibrillation and risk factors for thromboembolism should be adequately treated with chronic oral anticoagulation to avoid any future thromboembolic events. For ventricular arrhythmia, these arrhythms are common early after myocardial infarction and not all required intervention. Generally, the mechanism for these arrhythmias is multifactorial, including ischemia, hemodynamic abnormality, electrolyte imbalance, re-entry, enhanced automaticity. The incidence of this arrhythmia declined over recent decades due to early coronary perfusion strategy and early use of beta blocker. Ventricular premature beats are very frequent on the first day of acute phase of infarction. About 6 to 8% of patients still develop hemodynamic significant malignant ventricular arrhythmias, and these arrhythmias may occur also at time of restoration of coronary blood flow reperfusion arrhythmia, and for this arrhythmia no specific treatment is necessary, and usually they are benign. For the management, beta blocker are recommended if no contraindication. Urgent coronary perfusion is the most important uh, factor to decrease the trigger of this arrhythmia. IV amiodarone is recommended for recurrent VTAC in addition to a correction of any electrolyte abnormality, especially hypokalemia. In patients who develop electrical storm and frequent VTAC, overdrive stimulation may be helped to control this situation. And in certain situations, successful radiofrequency ablation in a specialized center has been shown to abolish recurrent VTAC or VF. Most important, we have to know that it is contraindicated to give antiarrhythmic drug as a prophylactic treatment, and for patients with asymptomatic and hemodynamic relevant ventricular arrhythmia should not be treated by antiarrhythmic drugs. For ICD therapy is recommended to reduce sudden cardiac death in patients who are symptomatic with heart failure NIHA class more than 3, left ventricular ejection fraction less than 35%, despite optimal medical treatment and proper assessment after 6 to 12 weeks after revascularization. For the conduction disturbance, first degree heart block does not require treatment. Sinus bradycardia and second degree heart block type 1, common in inferior infarction. No treatment may be required. Patient with severe hypotension could be treated by intravenous atropine, and coronary revascularization is a mandatory treatment strategy. Second degree heart block type 2 may be indication for pacing. For complete heart block, AV block with the inferior MI usually suprahiscent, usually resolved spontaneously or after coronary perfusion. AV block associated with anterior myocardial infarction is usually infrahiscent, and this evidence of high mortality rate due to extensive myocardial necrosis. The third common complication is the mechanical complication. Mechanical complications are classified based on their onset after the primary event. It could be acute or subacute within days to weeks, or chronic within weeks to years. The common underlying mechanism for mechanical complication is excessive transmural myocardial necrosis, followed by rupture or extensive scarring of the affected tissue. Generally, the incidence of these complications reduced after the routine use of primary reperfusion therapy in management of myocardial infarction. First, the free wall rupture. Free wall rupture may occur in less than 1% of patients during the first week. Commonly occurs in older age patients who lack of coronary perfusion or late perfusion. Papillary appear to be associated with an increased incidence of cardiac rupture. For these patients, from surgical point of view, we have two types: the oozing type without an obvious bleeding source, and the blood slowly accumulating in the pericardial sac, or the blowout type with a large macroscopic defect and high volume of bleeding cause abrupt pericardial tamponade and death. The clinical presentation reflects these two varieties. Symptoms initially no symptoms, or initial symptoms could be ranged between minimal chest pain up to severe chest pain and sudden collapse and sudden death. Echocardiography and stable patient CMR play an important role in showing the defects and evidence of hemopericardium and tamponade, and to show an anatomical feature to guide the surgical intervention. The management: acutely precardiosynthesis as a life-saving procedure, then hemodynamic stabilization and immediate surgery, either closing this defect by pericardial patch or other materials. However, the mortality rate is high, reach up to 75% in acute stage. Incomplete rupture of the heart may occur when organizing thrombus and hematoma together with pericardium seal this rupture of the left ventricle, and thus preventing the development of the hemopericardium within time. This area of organized thrombus and pericardium can become a pseudoaneurysm with a narrow base, and it is different than the true aneurysm, where an abnormal protrusion of the vascular wall containing all the layers of the original structure, which always contains some of the myocardial element in their wall. The diagnosis of LV aneurysm or pseudoaneurysm, usually done by echocardiography in stable patient with CT or CMR. The differential diagnosis of true and false aneurysm is challenging. However, by echocardiography may show this kinetic area of the left ventricle. So the use of CT and MRI sometimes is necessary. For the management, the indication of surgery is presence of large aneurysm with heart failure to prevent complications of myocardial rupture or thromboembolic event or serious arrhythmia. The percutaneous intervention or repair is advised only in as a bail-out strategy for critically ill patients whom surgery is not suitable. For ventricular septal rupture, the incidence is 1 to 3%. It's usually less with patients who underwent reperfusion. The time of onset usually range between 1 day to 14 days. There is two types: the simple type with simple ventricular rupture, or complex type. The clinical presentation usually sudden chest pain or progressive shortness of breath and hypotension. Clinically, a new harsh systolic murmur and F3 gallop and pulmonary edema is the usual presentation that can be deteriorated rapidly to cardiogenic shock. Echocardiography play an important role in diagnosis of this ventricular complication. Usually, the septal rupture can be shown with shunt between the left ventricle and right ventricle, and this picture showing a simple type apical ventricular septal defect, and other down here showing a complex ventricular septal defect. In a stable patient, we can go for right side catheterization with increasing the oxygen saturation from the right atrium to RV with large V wave in the tracing. In patients with a small or large VSD with stable hemodynamics, consider delay of surgery intervention is mandatory. And adopt a conservative strategy with close monitoring and after-load reduction to increase the effective cardiac output and reduce the shunt. Intra-aortic balloon provide a mechanical after-load reduction and augmentation of the cardiac output can be considered. And routine care, even in patients who remain hemodynamic stable, is essential in this stage. Medical therapy consists of diuretics, inotropic support, vasodilators, and intra-aortic balloon. Early surgery is associated with high mortality rate, reported to be 20 to 40%, and high risk of recurrence of ventricular rupture, while delayed surgery allow easier septal repair in scarring tissue, but carry the risk of the rupture, extension, and death while waiting for surgery. For this reason, this early surgery should be performed in all patients with severe heart failure that does not respond to the aggressive medical therapy, but delayed elective surgical repair is better. Another option is percutaneous closure of the defect, which appear designed with specific devices and can be an alternative for surgery or for patient who is sick and cannot go for surgery. This study examined the data provided by the STS group with more than 2,800 patients with post-myocardial infarction VSD who underwent surgical repair. The mortality varied significantly depending on the timing of the surgery. Patients who underwent surgery early, within 7 days, had a 54% mortality compared to 18% for patients who underwent surgery later on after 20 days. The mortality rate is the highest, 60% in patients who underwent operation in the first 24 hours. And the surgical correction can be done by a pericardial patch or to do an Teflon graft within the ruptured area. In the past decade, we witnessed an evolution in the structural cardiac intervention. This results into that percutaneous option for the closure of VSD in patients with significant risk for surgical repair is there. Could be an alternative for a definite strategy for repair or as a bridge to the surgery after initial stabilization. But still, the mortality rate is high in patients who underwent this procedure early after myocardial infarction as surgery. Second, papillary muscle rupture. Papillary muscle rupture occur after MI as a result of ischemic necrosis of the papillary muscle anchoring the mitral subvalvular apparatus. It may be partial or complete. Usually approximately 1% in the posteromedial, frequently then the anterolateral papillary muscle because the posteromedial has just one blood supply, but the anterolateral papillary muscle have dual blood supply. It usually occurs within 24 hours up to 3 to 5 days with range 1 to 14 days. The clinical presentation is sudden shortness of breath, pulmonary edema, and hypotension. Clinically, this new onset of soft murmur in some cases, but not rare. Echocardiography play an important role also for showing the torn papillary muscle or the chorda tendini, the flail leaflet, presence and assessment of severe mitral regurgitation, and showing hypocontractile left ventricle. The treatment based on afterload reduction to reduce the regurgitative volume and pulmonary congestion by intravenous diuretics, vasodilators, and inotropic support, as well as mechanical support per intra-aortic balloon for stabilization of this patient until urgent angiography and surgery. The surgical option for patients with ongoing ischemia and heart failure not respond to the medical therapy. For total rupture with bileaflet prolapse or flare valve, valve replacement is the preferred strategy. However, for partial or incomplete rupture of the valve repair is the treatment of choice. Percutaneous therapy with edge-to-edge repair mitral clip for extreme high-risk patients is there, but it needs an high centers with the well-trained operators and well-equipped catheter and center to do this such and high-risk procedure. Then we can go to other complications that could occur post myocardial infarction. First, pericarditis. It may be early or late. Late is the Dressler syndrome. The timing usually is from 2 to 4 days or later, 1 to 2 weeks post myocardial infarction. This now is era of prime PCI. This complication is less seen now. And patients who develop this condition usually have large infarctions, lower ejection fractions, higher incidence of heart failure. Patient usually presented with pleuritic chest pain. This pain increases with respiration and movement and leading to trapezius muscle. Clinically, this is a precardial fraction wrap. There's an ECG changes in about 60% of the cases with wide spread of ST segment elevation, PR depression in acute phase. There is evidence of pericardial effusion in 60% of cases, but usually it's mild. The treatment, the anti-inflammatory therapy is the recommended treatment in these patients for symptom relief and reduction of the recurrence. Aspirin up to 1 gram every 8 hours or 1 to 2 weeks that can be gradually decreased up to 50 to 500 gram every 1 to 2 weeks. Colchicine is recommended as a first-line therapy as an adjunctive to the aspirin and non-steroid anti-inflammatory for 3 months and in chronic cases and recurrent cases up to 6 months. Corticosteroids are not recommended due to the risk of scar thinning and aneurysm development or rupture. Anticoagulation are relatively contraindicated to avoid hemopericardium. And for pericardial effusion, those with massive pericardial effusion or evidence of tamponade pericardicentesis is mandatory. Then for patients with myocardial infarction can presented with pulmonary embolism, which usually came from leg DVT or RV thrombi, prolonged bed rest and heart failure predisposed for this thromboembolism. So early immobilization and using of anticoagulation, low electrolyte heparin is mandatory as prophylaxis to avoid this complication. For LV thrombus and arterial embolism, early mural thrombus can occur within 2 or 3 days post myocardial infarction. Usually it occurs in large myocardial infarction and carry poor prognosis. Systemic embolization occur in approximately 10% of these cases. Echocardiography could show the akinesis of the apical segment and visualize the thrombus, which must be assessed in multiple views. For this patient, initially heparin must be given, then long-term anticoagulation is mandatory. Nowadays, NOACs they are not licensed for the treatment of this thrombus. However, there is a growing evidence that these NOACs have a promise to reduce the risk of embolic event after randomized studies. The second part of this talk is the risk stratification after myocardial infarction. The process of risk stratification following ischemia occurs in several stages. First, the initial assessment after admission, and then during the in-hospital course, and finally at time of discharge. During this journey, many tools used to form an integrated and dynamic assessment of the patient, which consists of baseline demographic data and serial ECG, the presence and elevation of cardiac biomarkers, the hemodynamic monitoring during hospitalization, the non-invasive testing, and cardiac characterization. Initial evaluation, certain demographic and historical factors showing worse prognosis in patients presented with STEMI. This including elderly patients, those with more than 65 years, and diabetics. The data show that diabetes is associated with more than 40% increase in adjusted risk for death by 30 days, and surviving diabetic patients also experience more complications such as heart failure and post-myocardial infarction angina, and these complications are attributed to accelerated atherosclerosis and high risk of thrombosis and heart failure associated with diabetes. Second thing, the patients who have prior MI also have a risk of development of heart failure and more complication. Then the site of the myocardial infarction itself. Those patients who present with anterior myocardial infarction have a mortality risk more than those with inferior myocardial infarction, and those with right ventricular infarction complicated inferior have a higher mortality rate than those sustained just inferior myocardial infarction. Patients with multiple leads showing a segment elevation and high sum of segment elevation have increased mortality rate, especially if this infarction is anterior. Patients who demonstrate persistent advanced heart block have a worse prognosis than those patients without this abnormality. Second, during hospitalization. Hospital mortality from STEMI depends directly on the severity of left ventricular dysfunction, so this stratification incorporating abnormality of the vital signs, heart rate, systolic blood pressure, presence of heart failure, shock, cardiac arrest during hospitalization. All these factors are important in risk stratification of patients during discharge. Estimation of the infarct size in appropriate patients using an invasive hemodynamic monitoring provide an assessment of the likelihood of complicated hospital course. Third, both short-term and long-term survival after myocardial infarction depend on three major factors: the resting left ventricular function, the residual ischemic myocardium, and the susceptibility to serious ventricular arrhythmia and sudden cardiac death. The most important factor of these are the left ventricular function. So, assessment of left ventricular function is the one of the most important things, because LV function is one of the strongest predictor of survival in patients with STEMI. It's extremely important for risk stratification, commonly evaluated by LV angio during the time of catheterization or simply by transthoracic echo. Because of this dynamic nature of LV function recovery after STEMI, the timing at index of early hospitalization and then later on during hospitalization is an important factor. Assessment of the global and the regional function is mandatory, and for residual viable myocardium evaluation after 40 days at least, particularly with those patients who need ICD, is mandatory to be sure that the patient recovered from stunning, if there's stunning. The assessment of the residual viable myocardium could be done by exercise test or pharmacological stress echo. Those can be exercise, stress imaging perfusion study, a PET or a CMR, and no study show one imaging modality to be superior to the other, and the clinician must be guided by the availability and the level of expertise with the given modality. The non-invasive testing pre-discharge is an important tool um, for assessment of presence and extent of inducible ischemia in patients with STEMI who have not undergo for coronary angiography and do not have high-risk clinical features for doing angiography. The value of exercise test is to assess the functional significance of the non-vascularized coronary or non-obstructed artery. Um, Pre-discharge exercise may provide a psychological benefit to the patient for self-confidence and permit a detection of profound ischemia or other indication of high risk that could be associated with after post-discharge. Also, it can be used for evaluation of the efficacy of the medical treatment pre-discharge and assess the risk of subsequent cardiac event. The optimal timing for the vocative test for ischemia after MI remain unresolved. The modality for assessment could be exercise treadmill tests, and low-level exercise testing after MI appear to be safe, particularly stable patients. Those patients with no angina or evidence of heart failure with a stable ECG within the next 3 days after the index of hospitalization. Two different protocols can be used. The traditional submaximal exercise test done within 3 to 5 days. There is no complication. The exercise test, we can exercise the patient until symptoms occur or ECG changes or target workload of 5 minutes to be achieved, or a symptom-limited exercise test that also can be done after 5 days of hospitalization without stopping the test at a pre-specific target heart rate or metabolic equivalent level. A pharmacological stress test by echo and perfusion can be used. It is safe totality in uncomplicated patients. Finally, the additional to the determination of the left ventricular ejection fraction, several other non-invasive strategies have been proposed for identification of patients at risk from arrhythmogenic events after STEMI, such as single average or high QT dispersion, ambulatory Holter monitoring, baroreceptor sensitivity, measurement of heart rate variability. All of these tools can be used. However, because of this, their limited performance and characteristics, so the performance of this test is not routinely used. In addition to reduction of mortality achieved by standard pharmacological therapy, there are two weapons used for reduction of sudden cardiac deaths in such patients, which is coronary vascularization and use of ICD. So, according to the European and American guidelines, ICD therapy is recommended to reduce sudden cardiac deaths in patients presenting with symptomatic heart failure, left ventricular ejection fraction less than 35%, in spite of the medical treatment, and they must be assessed carefully after 3 months of the myocardial infarction. And those patients, especially for those patients, expected to survive at least 1 year with good functional status. Thank you so much for your attention.